Hello. Welcome to the Transplant Center at Northwestern Medicine. My name is Dr. John Friedewald, and I'm a transplant nephrologist. That's a kidney doctor who takes care of people who need or have had a kidney transplant or a pancreas transplant. And I'm going to talk to you today about our Transplant Orientation and Education Day, called our TOAD visit. And it's really what you need to know about a kidney and a pancreas transplant. So again, we look forward to meeting with you in person soon and talking to you in more detail about this, but we wanted to put this video out there so that you could get this information ahead of time, view it as many times as you need to, and then bring questions when you meet with us in person. So Chapter 1, who needs a kidney transplant? First off, let's cover what the kidney does and what kidney failure is. One of the key roles of your kidneys is to clean and filter the blood. And as you lose kidney function, we call that GFR in the business, toxins that are in your blood are not filtered out of the blood, and that buildup of toxins can make you feel sick. Kidney failure, or end-stage renal disease, means that your kidneys are not filtering enough of those toxins to keep you leading a normal and healthy life. It's that time when you reach that end-stage renal disease that we need to step in and help, either by doing dialysis, which filters the blood artificially, or with a new kidney through a kidney transplant. And so for people with end-stage renal disease, shown here, these are the treatment options for kidney failure. And until about the 1950s, there was only one treatment for kidney failure, which was nothing. We had no way of treating people with kidney failure, and people completely died of kidney failure at the time. Thankfully, in the 1950s, two main treatments evolved, one being dialysis and the other being kidney transplantation. And so the options to do would be do nothing, and some people choose not to proceed with treatment for a variety of reasons. Then there's dialysis, and we won't go into a lot of detail about dialysis, but as I mentioned before, dialysis is an artificial way to remove toxins from your bloodstream. And then there's a transplant, and that can come either from a deceased donor, which is someone who just recently died, or from a living donor, someone with two healthy kidneys who can give one up to you. We'll talk more in a minute about both compatible and incompatible donors and how we have found ways around that. So the question is, what should I do? Should I get a kidney transplant or should I go on dialysis? Which is better? And I think the answer has been pretty clearly determined now that for most people, the vast majority of people, they do much better and live a lot longer with a kidney transplant compared to being on dialysis. And that's shown here. No matter what age you are, from age 20 all the way down to age 75 to 80, you can see that on average, people live a longer life with a transplant, shown in blue, than compared to being on dialysis, which is shown in orange. Now, this doesn't apply to all people. Some people do not qualify for a transplant for reasons that we'll talk about in a few minutes. And so some people actually would live longer and better on dialysis. But thankfully, the vast majority of people do qualify for a transplant, and that does give them a new lease on life. So some common facts about transplant. First, as I just mentioned, kidney transplant improves the quality of life and lengthens life compared to being on dialysis if your general health is good. And part of our evaluation process is to make sure that you're healthy enough to benefit from a kidney transplant. And as I mentioned, not everyone does. It also improves the quality of your life. Many people who get a transplant can travel and work and do things they couldn't do while they were on dialysis. Start a family, for instance. So in most cases, the benefit of the transplant outweighs the risk. So what are the risks of having a transplant? That's important to consider as we think about whether this is the right treatment for you. There, of course, is a surgical risk. You have to have surgery, and as we like to say, it's more than just a haircut. And so when we meet you, we'll decide how risky the surgery might be. For some people, surgery is fairly low risk, but for some other people who may have heart problems or lung problems, being put on a ventilator during surgery can be a risky thing. And so we'll talk to you about what your risk is of having a surgical complication related to the actual transplant event. But beyond the transplant surgery, there are a lot of medical things that could happen afterwards, and we worry about those as well. So having a kidney transplant, while it does improve your overall health in most cases, can have other complications, both from the medications we use that we'll talk about more in a minute, the immune suppression, and other things. And lastly, there's some psychosocial risks. Going through a transplant, the changes that happen, sometimes the transplant is successful, and what could that do to you? And so we like to talk about all those possibilities as you consider whether this is the right treatment for you. As I mentioned, we have to use medications to keep the transplant working. The reason for that is that your body has an immune system, which is your body's defense. When we give you a kidney from some other person, your body sees that kidney as a foreign thing and is very well suited to destroy it, and that's what it's supposed to do. We need to fight against that. We give you medication to prevent that called immune suppression, because it suppresses your immune system, or anti-rejection medicine. And again, we'll talk more about this later. There's even risk from the organ itself. And what does that mean? When we give a kidney from one person to another person, that kidney can bring things with it, sometimes things we don't want, like infections or even cancer can be passed from a donor to a recipient. Now, we do a lot of careful screening of donors, both living and deceased, to make sure they don't have either infections or cancers that can be passed along with the kidney. But you can imagine after doing lots of transplants over decades, it does happen in rare cases. There's more information on our website here that I show you here. And just to mention, I put a lot of web links in this discussion if you want to go through and dive into more detail. But we developed a website that helps inform people about the risk of infections passing from the donor to the recipient, and you may find this useful if you have time to take a look at it. Suffice it to say, we test the donor for all the known infections that we know of to make sure that something can't be passed along from the donor to the recipient. Okay, so you've decided you want a kidney transplant based on what you've seen so far. How do you go about getting a kidney transplant? That's what we're going to cover in Chapter 2. So we have a broad team that gets you successfully transplanted. And I always say it takes a village to raise a kidney. And so you can see all the members of our team contribute to your overall success. And that includes transplant physicians like myself, transplant surgeons, social workers, transplant nurse coordinators, pharmacists, dietitians, and a whole host of other support staff who make this all happen for you. And you'll get to know all of us along your transplant journey. So how do I qualify for a kidney transplant? Well, the first question is, do I have to be on dialysis to be able to qualify for a transplant? The quick answer is no, you don't. You can get on the list for a kidney transplant before you start dialysis. Now, some smart person might say, well, why don't I just get on the list when my kidney functions normal, and that way if I need one someday I can get a transplant. And that's a good idea, but unfortunately the rules don't work that way. You do have to have advanced kidney disease, and that's defined as a GFR number less than 20 mLs per minute. So a GFR less than 20. Most people don't need dialysis till the GFR is closer to 10. So there is a period of time there where you can get on the list before you need dialysis. And that's the way to go if possible. If you're already on dialysis, we'll get you listed and transplanted as quickly as possible. But if you're not, it is a good idea to get evaluated and started when your GFR is close to 20. So we can start the evaluation prior to your GFR of being 20, but we can't start waiting time until it gets below 20. That's an ideal time to try to find a living donor and finish your evaluation. And we'll go through some of the steps of evaluation in the next few slides. Our transplant center has protocols and criteria for who can qualify and benefit from a transplant, and you'll be notified when your evaluation is complete if you qualify, and we'll talk more about that. We also, after you're listed for a transplant, may check in with you periodically and have you visit us here at the transplant center to make sure you remain a candidate while you're on the list, as things can happen over time. So what's the process to get a kidney transplant? What's the next step, and how does the wait list work? Well, the first question is, do we think you're a candidate for a transplant? I've shown you that most people with a transplant do better than being on dialysis, but I mentioned that's not for everybody. So some people may do worse with a transplant than dialysis. And you can imagine, for instance, as an example, if we need to suppress your immune system, that can put you at high risk of getting infections. And if you're someone who has lots of infections already, that may not be a very wise move. And so part of our evaluation through your history and physical exam will be determining what your risk is of tolerating the immune suppression. So we want to make sure you're a candidate. That means going through all the phases of our evaluation. In addition to our in-person visit, which we'll have, and potentially a phone call where we'll go through your history with you, we'll do some additional testing. Every person considering a transplant needs to have up-to-date, age-appropriate medical and cancer screening, and so you may potentially need a colonoscopy or a mammogram, depending on who you are and what age you are. We will tell you all the testing that was required to be listed and evaluated, and we can't determine if you're a candidate until you complete all that testing. So we want you to do your testing in a timely fashion. Here we say 12 weeks. Why do we say that? We used to say go get your testing done, and some people would take a year to get a chest x-ray done. This is really important, requires a lot of resources to help you get to the ultimate goal, which is your transplant, and we want you to do it quickly. So we ask you to do it within 3 months. Where you do your testing is up to you. It doesn't matter to us as long as we get the results. We can work with your doctor who sent you here to get your testing done in the most efficient manner possible. But once we get all that testing done, then we can decide if we think you're a good candidate for a transplant. So then we put you on the wait list. How does the wait list work? It's different for different organs, and I'll run through these quickly. So the waiting time and wait listing for a liver transplant is different than a heart and a kidney and a pancreas. So a liver, for instance, waiting time has nothing to do with who gets a liver transplant. In fact, livers are given out to who is the sickest. And that's determined based on a series of blood tests that develop a score called the MELD score. The higher your MELD score, the sicker you are, and the higher priority you are on the list. It has nothing to do with waiting time. On the flip side, kidney transplant is primarily driven by waiting time. So shown here, the points are given out primarily for waiting time. Each year, you get a point, and you get parts of a point for parts of a year. There are some exceptions. We give kids and pediatric patients priority on the list, anyone under 18. The reason for that is that kids don't grow and develop normally when they're on dialysis, and they do with a kidney transplant. So we want to give kids the opportunity to grow in a healthy manner. And so kids get to go ahead of adults. There are some other examples of some other priorities. So if a person out there dies and they're a perfect HLA match, a tissue type match for you, which we'll cover in a minute, those get prioritized because those transplants do extremely well. And so that's called a zero mismatch, and that's a national priority. So if someone out there dies and they're a perfect match for you, you're prioritized up to the top of the list. And likewise, if you have lots of antibodies, if you've had blood transfusions, a prior transplant, or pregnancies, those are ways that you can form antibodies against other people and make it harder to find a match. We measure those antibodies in a percentage score, and the higher your percentage means you have more antibodies, the harder it is to find a match, but you're given additional points to bring you up equal with everybody else so that everyone has a fair shot at getting a kidney. And so all these things go into the waiting time, into the score calculation, which is primarily, again, driven by waiting time. So when does waiting time start? Waiting time starts at either the time we list you if you're already on dialysis. If you're on dialysis, your waiting time backdates to the day you started dialysis. So if you've been on dialysis for 2 years when you come and see us, that isn't wasted time. If we list you, then your waiting time will go back to the start of dialysis. If you're not on dialysis, but your GFR is below 20, as we mentioned before, you can get on the list the day we add you to the wait list. So there is a sense of urgency there to get your workup done and get you on the wait list to start that waiting time. And from there, your time accrues. Okay, so we have a kidney available. How do we make sure it's a good kidney for you? How do we match a donor and recipient? Some of the basics we start with are shown here. We do three main ways of matching. The first is on blood type. And you may know about blood types, but as a quick review, there are 4 major blood types, A, B, and O. For transplant, the positive, negative doesn't matter, so you're just an O or an A as far as we're concerned. And like blood transfusions, the O is the universal donor. So shown here, a blood type O person can give to any other blood type. But in this example, an A blood type can only give to an A or an AB, not to an O or a B. So A to O doesn't work. And that's a problem because, unfortunately, these are not equally distributed throughout the population. So it's not like 25% of us are A and 25% are B, et cetera. In fact, most of us, almost half of us in the United States are blood type O, and about another 40% or so are blood type A. There are not many A's and ABs. And so very commonly, an A will want to give to an O, and they can't because the blood type is different. And the problem there is this person with the blood type O, their immune system has antibodies directed against that other blood type. And if we put an A kidney into an O person, that kidney can reject from those antibodies within a matter of minutes, and that's not something we want to have happen. So we avoid that. But again, as I said, it's a problem because let's say my brother is healthy and willing and wants to donate his kidney to me, but he's an A and I'm an O. We used to have to say, I'm sorry, that won't work. Nowadays, we have a way around that by doing something called a kidney exchange, and I'll tell you more about that in a minute. After we match on blood type, then we match on something called tissue type. And tissue type is how my immune system knows me from you. So my immune system generally leaves me alone in most cases, and anything else it kills. And that's a pretty good policy to keep us safe from invaders and infections and other things like that. But when we put a kidney from someone else inside of you, your immune system isn't smart enough to know that that's a good thing for you. And so it sees a kidney just like a big bacteria, and it's going to destroy it the way it would a bacteria. Well, how does it know friend from foe? It looks at these things called HLA antigens. And so we all have our own set of HLA antigens. There are lots of types in our body, but the 6 major, what we call tissue types, are what we use for matching. And it turns out if we find a donor who could be a relative or in fact a non-relative who have the same 6 major antigen types, we call that a perfect match. Now the only real perfect match is an identical twin, but that's pretty rare. True identical twins don't need any immune suppression because they have the same set of DNA and the same exact immune system. But anything short of that still can have a risk for rejection. But we know that these 6 out of 6 matches have a very low risk of rejection. That kidney looks a lot like yours, and that's a good thing. And we prioritize those. Where do we find them? Most commonly we find them in siblings because these are inherited from mom and dad. You get 3 from mom and 3 from dad. And so if you have a sibling, there's a pretty good chance, a 1 in 4 chance that one of your siblings may be a perfect match. So that's usually where we start if you need a transplant. Do you have siblings? Are they healthy and willing to donate? It turns out, though, in the short term, because of better immune suppression, a 0 out of 6 match does about as well as a 5 out of 6 match in the short term. And we know that because in the old days, before we had better immune suppression, this wasn't a very good thing. But now that better matching is less important with better immune suppression, it opens the door for a lot more people to donate, particularly non-relatives. So after blood type matching and tissue type matching, we then get to something called cross-matching. Cross-matching is the last test we do before the transplant, where we take blood from the donor and blood from the recipient and mix to see if there's an antibody response to the donor in you, the recipient. So that shows the two bloods here. And what we're looking for are antibodies to the donor's tissue type. Now, as I mentioned before, there aren't many ways to form antibodies against someone else, another person. You have to be exposed to their tissue type, and that happens three ways that we know. Either through a blood transfusion, a prior transplant of any kind, or a pregnancy. The mom sees the dad's half of the baby is foreign and can make antibodies. And so if you have antibodies to other people, we can test for that. And we want to make sure those antibodies, if you have them, aren't directed against your donor. And that's what this cross-match tells us. It tests compatibility. If the cross-match test is negative, we're good to go, and off to the transplant we go. If you have a positive cross-match, it's the same problem as having a blood type incompatible donor, and we have to come up with another solution, which I want to talk about next. So let's say we have an incompatible donor, an A blood type giving to an O or giving to a B. That doesn't work, as we mentioned before. What we can do is something called a kidney paired donation or a kidney exchange. And this developed a number of years ago, where we have one donor giving to a recipient, a B to an A, that doesn't work. But if we can find another pair out there where there's an A giving to a B that doesn't work, we can simply exchange the donors. B gives to B and A gives to A, and everybody wins. Very simple, very elegant. We've been doing this routinely in the U.S. for about 15 years. And it didn't really take off in the United States until about 2007, when the law that governs transplant, the National Organ Transplant Act, was clarified to say that this is legal. Initially, the law says you can't buy an organ. It doesn't say you can't buy an organ. It says you can't provide valuable consideration for an organ. And it was interpreted in a kidney exchange that giving a kidney to get a kidney was like paying for it. And so this was considered illegal under the law. Until 2007, when the Charlie Norwood Act amended the law and said that kidney exchanges do not constitute paying for an organ, and therefore this was adopted and became really widespread. And it's really helped a lot of people who had an incompatible donor find a successful transplant. We've been doing a lot of these here at Northwestern going back over the last decade. And you can see we went from very simple exchanges like this to very complicated exchanges like this. This is called a domino kidney pair donation chain. We did this back in 2010, so about 10 years ago now here at Northwestern, where we had 7 donors who wanted to give to 7 recipients. They were all incompatible for a variety of reasons. Along came a Good Samaritan donor shown here. This is someone who shows up and says, I want to give someone a kidney and do a nice thing. I don't know anyone who needs one, but I'm healthy and willing to do this. And we say, yes, in fact, you are healthy and willing to do this, and sure, that's great. Instead of giving it to one person, this domino knocks all the other dominoes over, and we can do 8 transplants instead. So in this example, you can see here that the Good Samaritan donor gave to recipient 1 in the end. That freed up donor 1 to give to recipient 7, and on and on. And so these domino kidney exchanges are a very powerful way to get lots of people successfully transplanted through the gift of one person who comes forward to allow all these other transplants to happen. I'll also point out that in this example, actually, there was one pair here, donor 5 and recipient 5, that were compatible. These were 2 friends. The donor happened to be blood type O, which is common, and the recipient was the rare blood type AB who can get a kidney from any blood type. We said you can give your friend your kidney, but if you're willing to go into the exchange program, you might help some other people out. And they said, sure, and because of that, these other people got transplanted as well. So one of the things we now talk about at our transplant center routinely is including compatible kidney pairs and exchanges. And what does that mean? The example here shows that donor 1 is actually blood type O and can give to blood type A, because O to A does work. But we asked that pair, if you're willing to go into our kidney exchange program, you might be able to give O to a B, which also works, and this person's A donor can give to you. That helps out this other pair, and that may in fact help out your pair as well. Let's say donor 2 is younger or healthier than donor 1. That may be a better kidney in the long term for this recipient 1, and by going through the kidney exchange, they may help someone else out and perhaps get a kidney that will work better for them as well. And so if you have a donor that's compatible, we may approach you about going into our kidney exchange to see if you can, number 1, help out other people, but number 2, maybe find a better match kidney for you as well. Okay, so to wrap this up, incompatible transplants, blood type incompatible transplants don't work well, but we have a way around that with our kidney exchanges. Also, people who have lots of antibodies sometimes have a hard time finding a compatible match as well. And we can do the same thing through kidney exchange for them, people who've had multiple blood transfusions or pregnancies, for instance, or a prior transplant. There's another option besides our kidney pair donation program. That's called desensitization. And desensitization is a series of medical treatments which can actually remove the harmful antibodies which cause rejection from the blood using a combination of treatments, including one called plasmapheresis. Plasmapheresis is a blood washing procedure a lot like dialysis. Instead of dialysis, which washes toxins out of the blood, plasmapheresis removes antibodies from the blood. And we can do that and remove those antibodies that would cause rejection and allow the transplant to be successful. These treatments are generally done about 2 weeks before and after the transplant, and the transplants do quite well. And so we offer both of these options at Northwestern, which is good because a lot of people used to come to us and say, I had a donor that was incompatible and I didn't have any other options, and here we can find a compatible transplant for you through one of these mechanisms. And we offer both of these options at Northwestern. If you want some more information, I put a link to the website describing that below. Okay, so what if I don't have a living donor? Let's say my siblings, I don't have any siblings or friends who can donate to me, or they all have medical problems where they can't donate. What do I do then? Well, the other option is to wait for a deceased donor. Generally, we prefer a living donor for a number of reasons, which I'll go through, but if not, we can wait for a deceased donor. The problem in the United States is there aren't enough deceased donors. So the waiting time for that deceased donor is now about 5 years on average throughout the U.S. and getting longer. So you can see that in April of just the last month, there were 95,000 people on the national waiting list for a kidney transplant, about 3,600 in Illinois. And in 2019, the last calendar year, in the U.S., we did 16,000 deceased donor transplant and 6,800 living donor transplants, which was a record, the most we've ever done. But it's still, this number added up is still a lot less than 95,000. And what that means is that people have to wait. And unfortunately, people can't wait forever. Although dialysis is an alternative therapy, you could see from the earlier slide, dialysis doesn't extend your life as long as a transplant can. And so some people can't wait long enough on dialysis, and they die before they get transplanted. And that's, of course, not how lists are supposed to work and how this is supposed to work. And so we work very hard on trying to find a way to get you a transplant sooner to avoid that exposure to dialysis over time, which can be bad for your body. If you want some details on this, below is a link to the UNOS website, which gives some information about transplant trends, how many transplants are being done, et cetera. So good question. So how does UNOS give out kidneys? How does this work? What are the rules? It's very transparent. So the rules that UNOS uses are all public and on their website. They form committees that are formed by professionals, patients, and other people to form these rules. And one of the first principles of organ transplants is we want to give out organs, kidneys, and pancreas and everything else, first in a local area, then a regional area, then a national area. And the reason for that, of course, is that with the deceased donor transplant, we can't have the organ outside the body for very long periods of time. You've probably all seen the videos of people running around with coolers full of ice, and that's actually true. We want to get the kidney out of one person into the next person as quickly as possible. So using it in a local area makes the most sense. But that gets complicated. And this shows the local map for UNOS. There are 58 local areas. They're called donor service areas. And you can see our donor service areas right here in the northern part of Illinois. What you can also tell is this map looks a little strange. It's not based on population density or anything else. You can see there aren't many organ procurement areas out in California where there are 30 million people, and there are 4 just in the state of Ohio. And so these cropped up not due to where patients were and who needed a transplant, but more to do with how hospitals contracted with these organ procurement organizations. And what this led to over time, because kidneys are first given out locally, then to a region, the region shown here, you can see we're in region 7, and then to the nation, is that these 58 donor service areas develop very different waiting times. Some people wait 2 years in one, and 5 or 6 years or 7 years in another. And one thing the national law says, governing organ transplants, is that people shouldn't wait longer depending on where they live. Well, fast forward through a lot of litigation and lawsuits, but eventually now these rules are changing. And I'll show you that next. But before I do, reminder that waiting time only applies to deceased donor kidney transplants. Living donor transplants require no waiting time. If my brother is healthy and wants to give me his kidney, as long as we're both ready to go, we schedule the transplant and do it right away. And so we can avoid that long waiting time on dialysis and the risk of your body deteriorating while you're on dialysis. So it's really important to talk to friends and family about being a living donor. It's hard to ask for things. We realize that. One thing I tell everybody is no one will offer to give you a kidney if they don't know you need one. So spread the word. And if you feel uncomfortable spreading the word, reach out to your friends and family. We've got something we developed called the Living Donor Champion Program, which helps to find someone to help you find a living donor. That's your donor champion. I gave a link to the website here, which has a link to our Donor Champion program that you can come and find out more information about how to be a donor champion. It gives you information about transplant, how to approach people, what to tell them, and how to get them connected with our Living Donor program to get a donor evaluated. It's really important because there aren't enough kidneys to go around. So I mentioned some changes coming to kidney allocation. In the last year, it's currently 2020, UNOS changed the rules about how organs are given out. Lungs, hearts, livers, and the last to come are kidneys and pancreas. And so what I showed here was the old map of local, and you can see our local area again is the northern part of Illinois. Coming in late 2020, the new local map will be a circle, a perfect circle around the donor hospital, a 250 nautical mile circle around that. So what's shown here is if the donor's in Chicago, the blue dots here are areas that are within that first local area, it's called. And you can see it crosses a lot of the previous line maps here, so it includes most of Wisconsin, parts of Iowa, all of Illinois, Indiana, some of Ohio, and Michigan. And so a much different circle around there, and what that will do, the hope of this is to equalize waiting times around the country. Again, this hasn't happened yet, and again, I put a link to the website at the bottom talking about kidney and pancreas policy updates that if you want to follow along, and we certainly will keep our patients updated as these rules change. It's a good thing for people in Chicago, though, because in general, Chicago and other big cities had longer waiting times than less populated areas, and this, we hope, will bring some equality to the waiting times around the country. Okay, so how do we decide the quality of a deceased donor kidney? Not all kidneys are created equally, and I always give the example of tires. It's like a tire. Some have 50,000 miles on them, some have 20,000 miles on them. All are good tires, but we don't have a limitless supply of perfect tires, and so we have to make some decisions about what you need. Now, the truth is not everyone needs 60 more years of kidney function, right? Someone in their 70s may be fine with not as long a time with a kidney. And the key is sometimes we can get a kidney a lot sooner depending on the quality. So how do we measure deceased donor quality? Again, all kidneys are good. Some work longer than others. So it depends on what you need and how quickly you can get it. UNOS developed an index called the Kidney Donor Profile Index, and that gives us an idea of what we think the longevity of this kidney transplant will be. And these are the variables that go into that. Obvious things like the age of the donor, how big they were, their ethnicity, whether they had high blood pressure, diabetes, their kidney function, etc. All these numbers get put together into a score that goes from 0 to 100. And that KDPI score is shown here in the bottom of this graph. 0 being the kidneys that are expected to work the longest, down to 100 the other end of the scale. And what this shows here is the 1-year and 2-year average graft survival. That's how long the kidney lasts. And what this tells us is, for instance, a donor with a KDPI score of 10%, 93.1% of those kidneys on average are still working after a year. And 89% are still working after 2 years. And you can see the numbers here. Importantly, this axis over here only goes to 60%, so 0 is way down here off the scale. And what you can see is that there's a pretty flat line until you get down to these higher numbers here. And so we actually treat kidneys from donors with a score of 85 a little bit differently. So there's what's called an opt-in system for donors that have a score over 85. Now, it's important to remember this score doesn't tell us everything. In fact, we get a lot more information beyond the score. For instance, we can do a biopsy of the kidney and look at the kidney. That's not included in the score. We can also put the kidney on a perfusion pump and look at the anatomy of the kidney. None of that is included in this score. This score is an early snapshot of the donor to give us a general idea of how long we think the kidney may last. This is not perfect, but it does help us make some decisions. And the way it works with kidneys with a score over 85 is you have to opt into this, which means we're going to ask you, do you want to even get a phone call about a kidney from a donor with a score of 86%, for instance? And you might say yes, you might say no. And the answer here is some people who want to have 40, 50 more years of kidney function probably want to wait for a kidney that's going to last them longer with a lower score. But some people are just fine getting a kidney sooner. And the big benefit here is there's significantly shorter waiting time for these kidneys because not everyone wants one. Now, when we ask you for this, we're going to ask you, do you want to get these phone calls? And if you say yes, all you're signing up for is a phone call. You can always turn down any kidney offer and wait for the next one. And you don't lose your spot in line. You just pass it to the person behind you. And so you always have that option. But for instance, some people we know probably don't want one of these kidneys. They want to wait for a kidney that may last them longer, and they're willing to wait longer. Some people may not live as long on dialysis. We know certain people don't do well on dialysis, and getting off dialysis with any kidney is the best option for them. They should jump at any chance to get off dialysis because that's the main risk for them. And so we'll give you some information about this and give you our opinion, and you can make your decision. Again, the benefit here is that you get these sooner. They may not last as long, but sometimes that's not a big deal. Getting it sooner is what really matters. And again, the alternative is a living donor transplant. We talk about this a lot because it's so important. We think living donor kidney transplants are the main way to avoid being on dialysis, which in the long term is not good for your body. And living donor transplants offer the best short and long-term outcomes with the least amount of waiting time. Let's talk about being a living donor. Let's say you want to give someone a kidney. What we know is that living kidney donors return to a normal life and health after donation. I always say that it's safe to take a kidney out of a healthy person. Now, I remind people the word safe does not mean risk-free, and there are risks to being a kidney donor. There's a whole other information session which will be available to you and anyone who wants to be a donor that goes into more detail about this. A living donor does not have to be related to you. We used to want a very close relative to donate, but as I mentioned before, with better immune suppression, we can have people who are non-related, particularly spouses, now consider being a donor. And the surgery to remove a kidney from a donor is minimally invasive. It's done laparoscopically, and the recovery is much faster. So in general now, living donors stay one night in the hospital after their donor surgery. It generally takes 2 to 3 weeks to recover from the surgery to get back to what you're doing. Now, some people who do a physical labor may take longer to recover, but 2 to 3 weeks is the average recovery time to be back to work. And again, the surgery for the donors is done with a camera minimally invasively through a laparoscopic approach. Other questions about being a living donor. Are living donors' tests and operation paid for by the recipient's insurance? And the answer is yes. If I need a transplant, my brother is going to be my donor, my insurance pays for all of his stuff. And that includes his testing, his hospital stay, his operation. He shouldn't receive a bill for being a living donor. Now, what my insurance can't pay for are things like his time off of work, any travel he may need to get to Chicago, for instance. Now, I mentioned earlier, but it's important to say that you can't buy a kidney. You can't give someone $100,000 to be your kidney donor. That's considered illegal in the United States. What you can do is offset what are called donation-related expenses. So I can pay for my brother to come here, to travel here, and I can help him with time off of work, but I can't give him an incentive to be a donor. Now, a number of people have realized that getting people off dialysis and transplanted with a living donor is the best thing for them. It's also good for insurance. It saves a lot of money. It's a cheaper way to go. So it's actually better for you and cheaper. And so some insurance companies have come around and said, you know what? Because we know this is the good way to go, we're willing to help offset the expenses of a living donor. So we'll check with you and find out, but some of the recipient insurances will actually pay money for donor-related expenses. If that doesn't happen, there's also something called the National Living Donor Assistance Center, or NILDAC here, and that's a pilot program through the government which also provides money to offset the cost of being a living donor. And those include things like travel, food, lodging, and time off of work. And so it's really important that we want to try to avoid donors having any incurred expenses for doing something so heroic, and there are ways to do that now. So we'll talk to you more about that if you want to be a living donor. Okay, transplant tourism, what's that? Some people say, look, I don't want to wait for a kidney here in the U.S. and I don't have a donor. I'm going to fly overseas and buy a kidney somewhere else. Can that happen? The answer is yes. There are a lot of places around the world that have a market for kidneys, either legal or illegal, typically illegal. And here at Northwestern, we recommend against that for a whole variety of reasons. Number one is some of the human rights abuses with donors going around the world. Number two is the safety factor. Now, importantly, some people say, well, look, my cousin lives in Mexico or Canada. Can they come donate a kidney to me here? And the answer is yes. That's not the same thing. We often have living donors come from both around the country and around the world to donate kidneys to people in need here. That's a very different story. But we would recommend against you going overseas and buying a kidney. There are a lot of risks involved with that. Okay. So what happens if a donor gets kidney failure later in the single kidney, and is that more likely to happen? So what we know is, again, that when donors give up a kidney, they lose some permanent kidney function. Now, most of the time, we do careful measurements of the donor's kidney function to make sure they can give up some kidney function. And they don't lose half their kidney function. In fact, the remaining kidney does increase its filtration capacity, that GFR, to get to back about 75% of what donors had initially. And so we measure the total kidney function to make sure that they can give up around 25% and still be healthy. What we do know about donors is that living donors over time have a high risk of developing high blood pressure, and that's something important to be monitored for. Women of childbearing potential can have higher rates of high blood pressure during pregnancy, or what's called preeclampsia. And of course, if they get pregnant, they should be monitored carefully for that. We're continually studying the safety of living donation, and we're learning a lot more about that. And those things tend to be the most common concerns about being a living donor. We also know that living donors do have a slightly higher risk of developing kidney failure. The good news is that risk starts at a very low level. Donation increases that risk, but that risk still is very low, even compared to the general public. And again, we have figures in the donor information session about all of that. And lastly, does a kidney donor need to take medications, change diet, or restrict activity? The answer is no. Donors go home with pain medicine for a few days after the surgery, but typically only for a few days. Diet, yes, we ask you to eat a healthy diet, and we generally recommend against super high protein diets because those can be bad for your kidneys. But in general, we don't recommend a specific diet. And activity is restricted while you're recovering from the surgery itself, but beyond that, there are no limitations on activity, and of course, we recommend a healthy level of activity. Again, the link at the bottom of our screen shows some information about the donors there, and I'll have a link to our donor information session as well. There are also links on our website if you want to be a living donor on how to fill out a questionnaire. If you're interested in giving to a recipient or a candidate for that matter, there's a link on there to go and fill out a history sheet that we can start your evaluation. Okay, back to the recipient and the transplant surgery itself. The recipient's failed kidneys are shown up here. They generally live up here behind your back, and they're left in place. We don't take those out in most cases. The new kidney is placed down here in the pelvis, right around the belt line, either on the right or left side, doesn't matter which side. That's shown here. We attach the kidney to the big blood vessels that run down into your leg, called the iliac artery and vein, and the ureter here takes urine down to the bladder, and in fact you have 3 kidneys attached to your bladder after the surgery. Now, some people have kidneys that need to come out for a variety of reasons. The most common one is people who have what are called polycystic kidneys, which can become very large, and they can become so large they take up a big part of the abdomen. There's not room to put a new kidney in. In those cases, we'll often take out one or both kidneys before the transplant, so there's room to put the new kidney in. But not everyone with polycystic kidney disease needs their kidneys out. We'll examine you and see how much room you have and see if we do need to remove a kidney. But again, the vast majority of people, the kidneys stay in place and just hang out there. A little information about some specialty programs we have here at Northwestern we're very proud of. The first is our Hispanic transplant program. This is a picture of Dr. Juan Carlos Caicedo, who's one of our transplant surgeons. He's also the director of our liver transplant program. He started a Hispanic transplant program here a number of years ago in response to a real need. The Hispanic population represents the largest minority group in the U.S., and there are more than 800,000 Hispanics in the city of Chicago, with almost 2 million Hispanics in the greater Chicagoland area. 75% of those speak Spanish, and only 25% speak English. Also, we know that people of Hispanic origin have higher incidence and prevalence of diseases that lead to liver and kidney failure. The risk to Hispanics is almost double compared to Caucasians. So in an effort to meet the need of this growing population, Northwestern Medicine has a comprehensive culturally sensitive Hispanic transplant program with bilingual team members and a dedicated transplant clinic that's all in Spanish. There's a Spanish phone line for patients, for referring physicians, clinic staff, and case managers, so you can speak in your native tongue or whatever's more comfortable for you. We also have a culturally sensitive coordinated care throughout to make sure that you're getting what you need when you need it. We have Spanish patient education materials and access to clinical research just like anyone else. We also have another program called our African American Transplant Access Program, and that's run by Dr. Simpson here, Dr. Danae Simpson. So African Americans also represent 13% of the U.S. population. They represent 35% of those with kidney disease. So it's an excess burden of kidney disease in this population. African Americans are nearly 4 times as likely to develop kidney failure than non-Hispanic whites, according to data from the NIH. Why? There are probably a lot of factors, but some of those are that African Americans are more likely to suffer from the top 2 causes of kidney disease, diabetes and high blood pressure. There may be genetic predispositions in some people. And there are additional factors that influence the disparities in kidney disease for African Americans, known as social determinants of health. These include things like economic stability, neighborhood living conditions, access to education, access to healthy food options, access to preventive health care, and specialty health care. African Americans are also more likely to have lower access to kidney transplantation, including living donors, and are shown to be less likely to complete the evaluation process once they start it. So Dr. Simpson, a Northwestern Medicine transplant surgeon, is the only African American female organ transplant surgeon in Illinois. And she's currently developing this African American Transplant Access Program to improve education and access for this at-risk community. Okay, Chapter 3. How do I keep my transplant healthy now that I've gotten one? So we'll start out with what's rejection. Rejection, in our terminology, is based on our body's immune system, our body's defense. And normally, this cartoon here shows our immune system fighting off all these invaders, infections. But the immune system sees the kidney transplant, as I mentioned before, as an invader as well, and wants to attack and reject it. Now, the good news is we can prevent rejection with medication called immune suppression or anti-rejection medicine. And in fact, when a rejection attempt starts, we can often reverse it with that same medication. But it's very important that we take your medication to prevent that from happening. So immune suppression medications have evolved over the years, and you can imagine compared to the 1960s and 70s, we've developed better and safer anti-rejection medicine with fewer side effects. And as I mentioned before, it makes the DNA matching between donors and recipients less important than it used to be. We wanted a really close relative to donate in the past. Now we can have non-relatives like spouses and friends donate with very good outcomes. Now it's important to remember the medicine to prevent rejection must be taken for the life of the transplanter, as long as you want to keep it. And we'll need to make sure you can get access to those medications, so our social workers and financial coordinators will make sure that you have insurance that will cover those medications and you can keep access to them. Because if you don't take the medicine, the transplant will reject and fail. That's guaranteed. So it's really important. We stress that a lot, and it's one of the best ways to keep your transplant healthy. The good news is with better anti-rejection medicines, now at our transplant center, lifetime prednisone is no longer needed in most cases. So we used to, and most transplant centers still use prednisone as an anti-rejection medicine. Prednisone, as you may know, can have lots of side effects, including weight gain, diabetes, bone thinning and fractures, cataracts, high cholesterol, etc. And so we decided a long time ago to change the medicines we use to eliminate prednisone from one of the long-term medicines. And we've been doing that now quite successfully for some time. Now, I always tell people prednisone is needed for some patients for other reasons, but again, the vast majority of people who get a kidney transplant or a pancreas transplant at Northwestern don't need to take prednisone, which is kind of nice. Okay, as mentioned before, anti-rejection medicine is required for life. It's really important that you take your medicine. And it seems simple, but it's actually not. We're all human beings. We have lives. We're busy. We forget. And so it's easy to miss medication. And so developing a strategy to remember to take your medicine all the time is so, so important. And we'll help you with that. We'll give you lists of your medicines with pictures. You can check them off. There are lots of apps on phones now to remind you. But whatever you develop, whatever strategy you develop, is really important to remember to take your medicine and keep your transplant healthy. Now, that being said, we don't like medicine. We realize the inherent problems with that. And weakening the immune system sets you up for risk for infections and even some certain types of cancer. And so we'd love to be able to do transplants and not need medicine. Can we do that? And the answer is yes, we think so. We do that through research called tolerance research. And we've been doing that at the Northwestern for about 10 years now. How does that work? Well, we hope to do a transplant and allow the body to accept the transplant without needing long-term anti-rejection medicines. And the way we do that is through what are called combined kidney and stem cell transplants. In this cartoon, a living donor gives a kidney to a recipient, and it has to be a living donor in these research studies we're doing. And we also take from that donor what are called stem cells. Stem cells are cool cells that can grow up and become anything. We get stem cells from the donor that we know are going to grow up to be white blood cells. Now, normally, white blood cells are part of our immune system that go and reject the transplant. But when these white blood cells see the transplant, they're from the same donor, and they leave it alone. They're tolerant of it. And that's the way this works. We've been doing these transplants, as I mentioned now, for the better part of a decade and have had great success with them. They don't work in everybody, and there are risks involved, but it's very exciting, and we now have a number of transplant patients who have had a transplant without need for long-term anti-rejection medicine with a healthy, functioning transplant. And so we certainly encourage you, if you're interested, to learn more about this. Again, I give a link to our website with our clinical trials, and you can reach out to us and learn more about this. We think the field of transplantation is evolving towards what we call cellular-based therapies. So getting away from needing medicines to suppress the immune system and using cells, either through this kind of stem cell transplant or even using special cells called regulatory cells, which regulate our immune system, and giving you doses of those over time to help suppress the immune response against the transplant. So again, we're really proud and excited with some of the research we're doing and want to make you part of it if you're interested. Okay, so what other complications or risks should I know about, and can I do anything to lower the risk of them? How do I stay healthy? Well, one of the main risks of suppressing your immune system is infections. Now, we do this very carefully. We have medicine that can wipe out your immune system, and you'd never have rejection, but of course you couldn't live without an immune system. And so we work to suppress your immune system very carefully to a point where you're not having rejection but can fight off infections. But that being said, you need some help. And the way to do that is to avoid infections. And we do that primarily through a couple things. And living in the time of this current pandemic, we all know that washing hands is very, very important, more so now than ever. But it is important. It's one of our best defense against getting infection. The way we get sick is we touch something and touch our face, and then we get that infection. So wash your hands. Vaccines are very, very important. Again, more now than ever. Some vaccines are not safe in people who have immune suppression. So any live vaccine typically is contraindicated in a person with a transplant. So it's important before you get your transplant to make sure that all your vaccines are up to date, particularly ones for things like chickenpox, which is a common infection in people with transplants. And then, of course, the seasonal flu vaccines and periodic pneumonia vaccines, we will make sure you stay up to date with. And lastly, common sense. During times of year when influenza is prevalent or other diseases, we need to make sure that you're staying away from people. It doesn't mean you need to live in a cave or stay at home, but you need to use common sense. Hand washing, vaccines, and common sense are a great way to live a normal, healthy life, but avoid getting infections. I also mentioned cancer is more common. We know that immune suppression can make certain cancers more common. The most common one is skin cancer. People with immune suppression, no matter their skin type, even people with darker skin tones, have high rates of skin cancer. And so it's really important to avoid the one thing we know causes that is sun. So again, routine cancer screening, you can see a dermatologist once a year, and they can catch skin cancer early and treat it successfully. And avoiding sun are two ways we know to reduce the risk of skin cancer. Beyond that, routine cancer screening for things that are age appropriate, like pap smears and mammograms for women, colonoscopies, prostate testing for men, are all important ways to catch cancer early if it develops and treat it successfully. Lastly, women of childbearing potential, there are some risks to getting pregnant if you're on certain medications. One of the medicines we use commonly to prevent rejection is called mycophenolate, and we know and have known for a while that mycophenolate can cause birth defects in women who are pregnant. And so it's important that if you're considering pregnancy that you let us know ahead of time, because we can take you off this medication and put you on one that's safer. And many women have had successful pregnancies after their transplant, but we need to plan for it and get you off medicines that we know can harm the developing baby. Any woman of childbearing potential, the Food and Drug Administration requires we have you sign a consent form knowing and stating that you know you shouldn't get pregnant if you're taking this medication, mycophenolate, and that you're using effective birth control if you're on this medication. We'll tell you more about that when we meet you in person. Okay, so do transplants last forever? Do transplants fail, when and why? So unfortunately, yes, transplants can fail. They don't last forever in everybody. The timing of how long a transplant lasts, again, varies tremendously, but when we look at averages, we can see that in general, transplants from living donors last longer, about 15 to 20 years on average, compared to those from standard deceased donors, which is about 10 years, compared to those from the donors, remember, with the score over 85, which is about 6 to 8 years. Now, again, This is not a warranty or guarantee. I have seen living donor transplants fail after a week. I've seen deceased donor transplants last beyond 40 years. And so how long your transplant lasts has a lot more to do with who you are, what medical problems you have, who your donor was, how well you take your medicine, and a whole variety of things. But it is helpful to step back and look at averages across a population to see what you can expect from a transplant. There's up-to-date information on outcomes can be found always at the Scientific Registry for Transplant Recipients, the SRTR website, we call it, srtr.org. So why do they fail? What's wrong? Why don't transplants last forever? The most common reason a transplant fails is the person dies of something else. So the transplant's working fine. We call this death with a functioning kidney transplant. Now, in our minds, that's not a failure. We'd actually love your transplant to last the rest of your natural life. We just want that natural life to be long. And so that reminds us, why do people with transplants die? The same reason most Americans die, cancer and heart disease. And so it's important before and after the transplant to make sure that we perform routine cancer screening, and that we make sure your heart's in good shape, and that you see a cardiologist and get treatment for heart disease if you have it, because those are things we know that can trip us up after a transplant and get in the way of you leading a long, healthy life. The second main reason is chronic rejection. Remember I said we could shut off your immune system, and that's a pretty bad idea. By keeping your immune system intact to fight off infections, it can also fight off the transplant. And it's a delicate balance between giving you enough immune suppression to prevent rejection, but not too much so that we get infections. But chronic rejection is that problem, so it's really important to take your medicines. We're constantly looking into new research and new ways to balance that rejection and infection and make that better. But right now, immune suppression is still the best way to keep a functioning, healthy kidney transplant. The next is recurrent disease. Sometimes the disease you had in your old kidneys can come back in the new kidney. Now, not in every case. Diseases like polycystic kidney disease never come back in a new kidney, but diseases like glomerulonephritis, whether it's IgA nephropathy or lupus or FSGS, can potentially come back in the new kidney. And high blood pressure and diabetes can damage your old kidneys just like they can damage the new kidney. So if you don't control your blood pressure or your blood sugars after the transplant, the same thing can happen with your new kidney. So it's a good reminder that we've really got to be on top of your blood pressure management and your diabetes management if you have diabetes. And lastly, there's some medications and infections that can harm the kidney. You probably know to stay away from certain medications if you have kidney disease. Some of the medicines we use for transplant can harm the kidney as well. One of the anti-rejection medicines that was first developed for transplant that really revolutionized the field was called cyclosporin. Cyclosporin can damage certain kidneys. Likewise, the newer cousin to tacrolimus can potentially cause kidney damage. It's not as common as causing kidney damage, and we try to limit the exposure to it, and we're constantly looking for new medicines that work better, but currently those are the best medicines that we have. And lastly, there are infections, one called the BK virus, which infects the urine in people. A lot of healthy people have BK virus infection. It doesn't cause much of a problem, but when we reduce your immune system with immune suppression, it can lead to an infection which can damage the kidney, and so we monitor you very closely for that after the transplant. Okay, I'm going to shift gears from kidney for a minute to talk about people with diabetes and pancreas and islet cell transplants. So this is a pancreas here. It sits right in the middle of your abdomen. Your stomach sits here, and this is your duodenum. So who needs a pancreas transplant? Well, the pancreas helps do a couple things for our body. One is help to digest food. The other is to make insulin. So people with diabetes, there are two types of diabetes, two main types. People with type 1 diabetes, formerly called juvenile onset diabetes, is caused by destruction of the cells, the insulin-producing cells are called beta cells in the pancreas that make insulin. So people with type 1 diabetes can't make insulin. And so they actually can't live without insulin. They have to have injectable insulin to survive. They can't use pills. That's type 1 diabetes. Type 2 diabetes is caused by a relative lack of insulin, or what we call insulin resistance. So your pancreas makes insulin, but it doesn't work as well. In those cases, people with type 2 diabetes sometimes can get by with medication to make the insulin work better, and sometimes a combination of insulin and or medication, pill medication. So both people, as long as you use insulin, can qualify for a pancreas transplant. If you have type 2 diabetes and only take pills, generally you don't qualify for a pancreas transplant. We know that long-term insulin therapy can be life-saving in people with diabetes, but still can result in kidney problems, vision problems, heart and blood vessel disease, like heart disease, and peripheral neuropathy, damage to the nerves, which causes numbness in the hands and feet. Again, there's more information about pancreas and islet cell transplantation on our website, shown on the link at the bottom. So what are the indications for a pancreas transplant? It has to be someone needing insulin, insulin-dependent diabetes, either type 1 or type 2. And in someone with type 1 diabetes or type 2 diabetes, they can do a couple things. One is if they have kidney failure and diabetes, we can do what's called a simultaneous pancreas and kidney transplant. That's a transplant of both organs at the same time from a deceased donor, where we take both the kidney and pancreas and transplant them together. We can also do, if you have normal kidney function and type 1 diabetes or bad type 2 diabetes, we can do what's called a pancreas alone, shown here. That's for someone who has very brittle diabetes, where your blood sugars go very high and very low. Or if you have a kidney transplant already and develop diabetes, we can do what's called a pancreas after a kidney transplant. And that's just a pancreas alone from a deceased donor. So there are a number of combinations here. And when we meet with you in person, we can talk to you more about what we think the best option is for you to get both off of dialysis and potentially cure your diabetes. With a successful pancreas or islet cell transplant, that can restore normal glucose levels without the need for insulin shots, without the need for frequent blood glucose monitoring. It can reverse early kidney damage in your native kidneys and or prevent damage in the transplanted kidney. It can stabilize visual changes associated with diabetes. And certainly we think improve quality of life, not having to worry about your blood sugar going high or low, testing your blood sugar frequently, or having insulin with you. And the evaluation for a pancreas transplant is very similar to a kidney and can be done during the same visit. So if you have diabetes, we will certainly talk to you about whether or not you may qualify for this and what those options mean for you. Okay, Chapter 5, to wrap up. Research and post-transplant expectations. So as I mentioned earlier, some of the research we're doing, we do a lot of research here at Northwestern. Part of our mission, not just to get you guys better and back to a healthier life, is to make transplantation better. And we've been doing this now for several decades, and we're very proud of the work we've done advancing the field of transplantation. In terms of clinical research, we always must obtain your consent for any and all research that you choose to participate in. It's always optional. But we invite you to be partners with us in this, and we realize that we can't do it without you. Our pledge is that we'll do what we think is the best and coolest research to make things better. And again, we need you as a partner in that, and we appreciate your trust you place in us. You may be contacted by members of our research team who will identify themselves and say, hi, I'm part of the Northwestern Transplant Research Team, and you're eligible for a clinical trial. Would you be willing to hear more about that? You can also approach us if you get information about a trial that we're doing. We're happy to talk to you more about that, whether you qualify for that and what it may mean for you. There are a lot of options available, and again, we encourage you to partner with us. You can learn more about our research here on our website that lists a number of our ongoing clinical trials. Lastly, what happens after your transplant? Post-transplant expectations. So after your transplant surgery, generally the stay in the hospital is anywhere from 2 to 3 days after your kidney transplant, if all goes well. After a pancreas transplant, it's about 5 to 7 days. After that, you go home and you have to adjust your new medications. As I mentioned, we give you medication to prevent rejection. We also give you some medications to prevent infections, a different cocktail of antibiotics. And so it's adjusting those medications is really important. As I said, it's one of the best ways to keep you and your transplant healthy. We do check your blood tests fairly frequently in the early part after the transplant. Those lab tests can be done either here at our hospital or at a number of satellite blood draw centers around the Chicagoland area or wherever you live. We do tend to see you in the clinic once a week for the first month, and then we spread those out to every 2 weeks, out to about the 3-month period. Beyond that, then we see you every couple months, and then after the first year, we see you on an annual basis. If you're on dialysis before the transplant and you have a catheter, either for hemodialysis with a catheter or a peritoneal dialysis catheter in your abdomen, we generally remove those as soon as the kidney transplant starts working. Now, for people who have a fistula or a graft in their arm, we don't routinely remove those after the transplant. And the reason for that is that the surgery, which is a quick surgery to close that off, once that's done, that fistula or graft can never be opened up again. And so we want to make sure, number one, that your transplant's working well. It's a nice insurance policy to have that in case something goes wrong with the transplant. Now, some people, their fistula gets large and dilated, it bothers them, their hand hurts, they have poor blood flow. Those are all indications to close that off a lot sooner. But if your fistula or graft is working well and it's not bothering you, sometimes we leave that in place. So we really do that on a case-by-case basis after the transplant, even if it's working well. Beyond 3 months, we see you less frequently, so you come to clinic at month 4, 6, 9, and 12. As I mentioned before, we do protocol kidney biopsies, so to check on the kidney. Even though your blood test may be normal, you can be having what's called silent rejection in the transplant. That happens about 1 in every 4 people. Doing a biopsy of the kidney can show us the kidney and see the white blood cells attacking the kidney causing rejection, and we can treat that. And so we do protocol biopsies on everybody at 3, 12, and 24 months after the transplant in our clinic. It's a same-day procedure to check the kidney and make sure it's healthy and not having what we call silent rejection. Beyond 3 months, we adjust your medication. The transplant medications to prevent rejection, we dose based on the level in your blood. So we check those blood levels fairly frequently to make sure we get the right dose. Once you get on a stable dose, we do those levels less frequently. But by 3 months, you should be back to your normal activities, whether that's going back to work, traveling, do whatever you want to do. After the 1-year visit, we see you generally on an annual basis if things are going well. After 3 months, we ask you to return to see your doctor that sent you here, either your referring nephrologist and or your primary care doctor. Again, at 24 months, we do our last protocol biopsy to check on the kidney. So initially, we provide all your care for the first few months after the transplant. That usually involves frequent blood draws, checking in, calling you, adjusting your medication, seeing how you're feeling. But eventually, at month 3, as I mentioned, we send you back to start partnering care with your referring nephrologist. Now, we always want to manage transplant issues, whether that's abnormal kidney function, infections, or transplant medication changes. We typically want to know about that, and that may be just a phone call informing us of what's going on, but we definitely want to keep track of that for the life of your transplant. But your primary care doctor and local nephrologist can do a lot to help us maintain you in a healthy way. That includes health screening and maintenance, medication refills and lab orders, routine cancer screening, blood pressure management, diabetes management, etc. And so as you get further out from the transplant, we start to partner in care with your local doctors to take care of you and seeing us on a less frequent basis, but always staying in touch with us, always making sure your kidney transplant's doing well. And that brings us to the end of our discussion today. I really thank you for your attention. We're really glad you've chosen to come and learn more about our transplant program here at Northwestern Medicine, and we really look forward to meeting you in person someday soon. Thank you very much.